I'm Gina Morangarambe, the managing editor of Harvard Public Health and today's moderator. We continue our Public Health in Action series today by focusing on Empower, a digital initiative to build a global mental health workforce. What's so innovative about Empower is that it draws from frontline workers like community health workers, peer counselors, social workers, and other people who might not have specialist mental health training, and teaches them how to deliver targeted care. These efforts to fill critical gaps in mental health care access and delivery come at a time when nearly 1 billion people worldwide have some form of mental disorder. Joining me today are Natalie Carmio, the project manager for Empower, John Nasland, an instructor of global health and social medicine, and the co-director of the Mental Health Lab for All at Harvard Medical School, and Catherine Sanchez, Director of Patient and Community Engaged Research Center and the Baylor Scott and White Research Institute Director of Diversity and Inclusiveness in Research. Thank you all for being with us today. It's a pleasure. Let's begin, if we might, by having each of you share in a sentence or two why you think Empower is so innovative.
No, thank you very much. Thanks very much, Gina. I'm really pleased to be here. So yeah, just to kind of start off, I think what Empower really brings to the table that's innovative is drawing from decades of pioneering research conducted in very low resource settings. So essentially taking rigorous science that's been developed in places where there really is limited access to mental health services and places where there are no psychiatrists. So thinking of sub-Saharan Africa or rural India, where a large portion of our work is based, and drawing from science that has really emerged from these settings, demonstrating that not only can you train individuals who don't have a specialized background in mental health care, but you can support them in such a way that they can deliver the same quality care as an even better quality care in some instances as a specialized provider. So that's a paradigm shift when we think of how you can treat mental illness. And what we're doing with Empower is how can we develop a digital platform that essentially can support this type of care delivery and bring it to scale. And thinking of this even in other settings, such as settings in the United States, where there's also very limited access to quality mental health care.
Great. Catherine, from where you sit, what innovation do you see?
I think the innovation that I see with Empower is twofold. One is the opportunity to really diversify the workforce, the mental health workforce. I think we have traditionally operated in a behavioral health workforce that is sort of on the high end of education and on the high end of licensure, and that has limited even the people who are able to provide those kind of services. So I think that one of the things that is critical is where it opens up an opportunity to be a provider, a lay provider, but a provider nonetheless, and in a much needed area, which therefore allows the opportunity to diversify that workforce. And the reason the diversification of the workforce is so important, which is the second thing that I think is extremely innovative, is the fact that it actually will provide access to a whole community of people who have not had access to mental health services, either because of a lack of adequate workforce, but also because of a poorly matched, what I think is so important is to have a culturally matched or racially and culturally and linguistically matched workforce to the patients or the people receiving services. People are most comfortable speaking with people who look like themselves and speak like themselves. And so the opportunity to basically expand access through this workforce of people that comes from their community and might even come from their neighborhood. So really, it's twofold. It's diversifying this workforce and creating and diversifying it, and then thereby providing access to a whole community of people who haven't had access.
And Natalie, how about you? What would you add?
Yeah, I agree with everything that has been said. I think also the procedures and the methodology that we implement to actually create all this content, implement this content, and deploy the workforce is also unique. And I think the rigorous scientific methodology that we apply in each of the steps also sets us apart from other programs and mental health trainings that are available right now in the field.
That's great. Thank you. Catherine, you're launching a new trial of Empower in Texas. What mental health care challenges are you trying to address with the trial?
Yes, we are very excited by this opportunity. We got some funding from the NIH, the National Institutes of Health, and this actually came out of a very special funding opportunity out of the NIH Director's Office, in which they were seeking basically transformative approaches to issues that have really had limited solutions previously. And so I think it's safe to say that what we're trying to address mostly is, depression, anxiety, psychosocial distress. Some of the things we know that, so for example, that social factors are what has come to be known as the social determinants of health, or actually have a huge influence on mental health. Just the daily experience of poverty or food insecurity or inflation or financial stressors, or even things like family violence or an incarcerated family member, are huge stressors that can actually create and lead to depression and anxiety in a community of people. And our goal is to be able to address those some of what we're going to address is the social factors, because through community health worker training, but then we're simultaneously going to be addressing mental health disorders, the daily experience of mental health disorders in a community of people that can be addressed, and through peers, really in a peer model. So those are the things we're looking at, really, is depression, anxiety, and some psychosocial factors that are strong influences on depression and anxiety.
Now let's hear from someone who has experience training with the program.
I chose to train in the Empower program because I am pursuing my degree in social work to become a licensed, to provide therapy. And so when the opportunity came, I just thought it would be good to have more information because it deals with mental health and behavioral health. So I just wanted to learn more. I think it's very important, or for me to take advantage of the opportunity more, if it was presented and it's for a study and I'm already working with research. So I didn't really see a reason not to participate. The hours that it required was a little not concerning, but that was maybe like the only thing that I was like thinking, will I have time? But I did, because they were very lenient. But the main reason I decided to participate was simply because I thought it would be a good idea to have just more, gather as much information as I can to kind of have it under my belt. I am hoping to help my community wherever I'm living. Also, just anybody, honestly, anybody that I am able to help, I want to provide assistance for them, and I want to be prepared as much as I can so that I could be a useful tool to them, and not, I just want to be useful, and I want to be ready. I want to be prepared so that way I can help whoever needs assistance. Also, not necessarily only Spanish speakers, but growing up the way I did, I know there's a lot of stigma around mental health. So a lot of times if someone does seem to be depressed, some of my family members will just say like, oh, they're just being lazy. They have no motivation. They're being lazy, this and that. So I do want to help my community in regards to like my Hispanic community, also just my community, like where I'm living, people who are struggling, but also just anybody. I feel like this could be applied to anyone, regardless of race, social status, anything, because we all have our troubles, and this is a tool. I've learned in school, there's several different, how can I say it? Like techniques you can use with a person. So this might work for somebody. If another form of therapy is not working for them, maybe the Empower training is what they need, which is, it focuses more on behaviors, like doing small changes in order to create a big effect on their life. But in general, I just want to help whoever needs the help, and I want to be prepared.
So Natalie, briefly, can you tell us a little bit more about how Empower works and what mental health issues the model works for?
Yeah, definitely. Empower is an umbrella program that aims to train frontline workers in different brief evidence-based psychosocial interventions to tackle the most common mental health concerns. So with that in mind, we have different projects that target different mental health issues. For instance, we have the project that we're working with Catherine is related to behavioral activation to address adult depression. We have Empower Youth that aims to train community and school workers to address youth anxiety and depression. We also have a peer support program with the goal of training people to address severe mental health illnesses. And we also collaborate in the Namaste project that aims to do parental training to address autism. But that's not, that's what we are currently working on. And we have a much higher, broader goal that we aim to create different programs to address all the most common mental health concerns. So for instance, substance abuse and alcoholism, and dementia and other neurodegenerative dementia and other and elderly care, also bereavement and PTSD, peri-traumatic stress, early child development, and so on. So those are kind of the different mental health concerns that we aim to address through the Empower platform. And different frontline workers can get trained on different projects according to the needs of their local communities. And in terms of how does it work, we have a very unique participatory approach. So we ask the communities that we aim to address to collaborate with us throughout the research process and the whole development of the content, to be a part of and to make sure that our content is culturally relevant and also appropriate to different communities. And we have that community engagement, not only during the creation of the content, but also when implementing. We have some guidelines, we have our procedures, we have our gold standards, but of course we discuss with each of the stakeholders and each of the organizations we partner with, what are the needs, how they are currently working, what are the challenges, and how can we best support them. And in terms of what type of interventions, the duration of the intervention and the duration of the training, of course, depends mostly on the technique that we are trying to use. But let's say, for instance, behavioral activation for adult depression, we provide a training for frontline workers to deliver 6 to 8 sessions in a structured, short way. And then we also provide training on how to refer in case that patients or clients are not improving and need a higher level of care. So that's, in a nutshell, how Empowers works.
That's great. I'm just going to roll you back for a second, Natalie. When you were talking about the higher level goals of the project growing, you mentioned some communities, including patients with dementia, PTSD. Can you tell me again a little bit about that?
Yeah, for sure. I think we aim to address, we currently have the projects of behavioral activation for adult depression, Empower Youth to address youth anxiety and depression, peer support workers for severe mental illness, Namaste project to train parents with children on the autism spectrum. And then we aim to create trainings, both or curriculum for PTSD and peri-traumatic stress, dementia and neurodegenerative conditions, care of the elderly, substance abuse, alcohol abuse, and early child development.
Thank you. So a whole spectrum of challenges that people face. John, I want to ask you a little bit about the global origins of Empower. We focused so far on Empower's work in the United States, but the model has been used in India for more than 20 years. Can you tell us more about what drove its development there?
Yeah, no, it's a great question. And so a lot of the foundational science for what Empower is built on. So it draws from the psychological sciences, which have historically been, came out of Western countries, out of academic sort of ivory tower settings like Harvard or other university settings like that. And they really, these sciences never really. Yes, they were beneficial. They showed that there's all kinds of behavioral techniques that you can use for addressing mental health concerns, but they really never reached a very wide section of the population, which is true even today. And these techniques were not, they really just lived on kind of, in academic journals and, books that collected dust inside these, libraries and so on. So in the context of the global south, so in lower resource countries in Africa or South Asia and even Latin America, there was a real dire need to address mental health concerns. I mean, it became such an apparent challenge. We saw this certainly in parts of Asia where really high rates of suicide have devastated communities. The same is true in many countries. So these concerns were rampant in people's villages and communities, and health practitioners and researchers in those countries had to think, well, we need to find a way to solve this problem. And this is an urgent, this is a public health crisis that's taking place right before our eyes, and there's no psychiatrist here. The idea of these Western models of mental health care just quite simply don't work in these settings, and I would argue they don't work in the U.S. or in the settings where these models are implemented. So they had to think creatively and think of innovative ways to deliver care in settings where there really was not a psychiatrist or a psychologist, not even one for hundreds of miles, but you could have a situation where there might be one psychiatrist for an entire country. So it just was completely not, and even the idea of training more psychiatrists or more psychologists was just not even possible. Even with additional funds, it would never, the number of years and time it would take would be impossible. So this is where these models of task sharing emerged. These models have also been widely used in for other health conditions. So, very, very successful for maternal and child health interventions, for instance, very successful for managing HIV care, for instance. These are examples, and were adapted for use for mental health care. So basically training lay persons, so they could be ordinary community members, could be community health workers, basically individuals that have some level of training, but not any expertise. They don't have a bunch of letters after their name. They don't have they haven't really had that level of training, but they don't need that level of training. I think that was really why this was such important research to conduct. So this was led by individuals such as Vikram Patel, from our department, and other researchers in other countries really pioneered these models. And that's right, it's started about 20 years ago, first showing that this could work. You could train community health workers to deliver proven behavioral interventions. The other key thing too is that there was more than just training. It was also a process of taking these behavioral interventions and adapting them to the local contexts and cultures. So Natalie referred to this kind of rigorous process of adaptation, and that was critical. Like, how do you take a model that's maybe drawing from some of the psychological sciences in the US or the UK, but how do you adapt that and deliver that in rural India, for instance? So there was very, very close involvement of the local communities, ensuring that, the term depression is not the same in every culture, every context. So even the idea of mental health is not the same in all settings. So I had to think carefully, how do you adapt the content so that it would align with the local understandings of that condition. What's fascinating with, I think, this entire process is that the impact of depression is consistent virtually in every culture, every setting globally. It has devastating impacts on people's functioning, their families, their livelihoods. But the way it's described and the way it's viewed within cultures is very, very different. So I had to think carefully about how to frame the intervention around the local context. And then this was followed by large-scale evaluations. And now we're at a point where there's such rigorous clinical evidence now coming from dozens of countries all around the globe, showing that when you train these providers and support them in a rigorous way, that the outcomes are excellent. I mean, they're on par with the highest level of trained psychologists or psychiatrists delivering the same interventions. So I think when we think of medicine in general or healthcare in general, it's an incredible paradigm shift to think that this is the type of we can effectively treat mental illness in virtually any setting. And what we're trying to do is now actually bring that to scale and basically make it work even in a country like the US.
And let's pick up a little bit more on that adaptation point. Natalie, you're part of the team that's helping to adapt this model that adapted to work in India back to a setting in the United States, where the work amounts to using a program in a different setting with a different language, different culture, different healthcare system, healthcare approaches. What's the first consideration that you all worked with as you thought about how to bring the model to the US?
Yeah, no, that's an amazing project and an amazing question as well. I think the first consideration is to really understand the the community and the culture that we are trying to address. What's their considerations of mental health, what are their current needs, the challenges, and how we can best understand what's going on so we can, how, as John said, frame the intervention around what their concerns are. So that's the first thing we do is take care and reach out to the communities that we are going to serve and ask them if they want to join us in a co-develop process of adaptation of the whole curriculum. And that involves not only the language, but all the cultural and contextual concerns as well. So let's say we wanted to transform the behavioral activation program into a Spanish version for Latino population here in the US. Community health workers, bilingual community health workers that are working in South Texas, they went through the whole training. We provided very detailed guidelines on the feedback that we wanted to get from each of the lessons, from each of the videos. Our trainings are video-based, so we have lectures and role plays that show how to use those skills in real-life settings. So it's very important that those videos reflect the places where these people are going to be delivering these interventions, the type of client, the type of household, and how they relate to each other. Like there are some cultures that are more like close and hugging people and touching each other might be more often, and some other cultures where, for instance, saying things like mental illness is really rude and will bring back a lot of stigma around that and prevent people from actually seeking for care. So having the right content is fundamental in terms of providing the intervention that we know is effective, but also how we frame it around language, around all the concerns that we display the clients having, let's say, immigrant issues and the stress related to that, or also climate concerns. That actually makes our trainings much more engageable and relatable and useful for our ends. And also during this process is both frontline workers, but also specialist providers that review and provide feedback about all the things I have already mentioned, but as well, like how should the actors look like, what the studio should be, how we can best tailor all the supplemental and complementary content that we create, the worksheets, all the questionnaires, everything around that to make sure that it fits the community from the beginning.
That's great. It's a lot to consider. Catherine, you've been a partner in that work and have seen the starts of it rolling out. There are big plans ahead. What advice would you give to other healthcare teams in the US that might be interested in deploying Empower?
Have patience. So they both just discussed the really, really important aspects. So John talked about the evidence base and the building of the evidence base and how we can make this work, how it has worked, how that team has proven that this model can work. And then Natalie talked about the adaptation for the communities and communities in the US, also equally important. And then we have a whole nother sort of adaptation and culture shift that has to happen in the health system. And that's what kind of that's our next hurdle. This is something that I really do believe can transform healthcare and can transform the delivery of behavioral health in a health system, but it's going to take time. And that's one thing that we've even sort of discovered working together. We started working together like 2 years ago, and I think we thought we'd roll out our pilot. I know I did. I thought we were going to be done in one summer, and it just wasn't. I mean, that's just not. And it's funny because on the provider side of things, I work with a lot of primary care physicians. I've done collaborative care and embedded behavioral health for years. I'm an LCSW. I'm a licensed clinical social worker by training. Like, this is what I do. It's what I did as a clinician. So the providers will tell you how much they need this and how much they want this, how much we need to have more behavioral health providers, how we need to have, embedded people in the primary care setting, understanding that having a licensed PhD psychologist in a primary care setting is limiting on so many levels, the cost, the space, all of the things. So what we're trying to do is shift some of the thinking. There's challenges. There's challenges around scope of work, scope of practice. There are the psychologists and the psychiatrists who are saying, whoa, wait a minute, who's going to be providing mental health services? Because there's that, right? Everybody has their own space and issues to protect around licensure with good reason. And And then, so even thinking about how we can do it, how can you provide care? How can someone provide care in this setting, but not be a licensed behavioral health provider? And that's why through the program, the training that we're doing, we're actually going to use community health workers so that they're in Texas. We have a community health worker certification. It is it is a widely accepted. Baylor Scott and White Health System already has 150 community health workers employed in the health system in what we think of as more traditional CHW roles, which is around patient education, chronic disease education, patient navigation. And so what we're wanting to do is take these folks that already exist in the health system as community health workers, and we just want to give them one more skill set. We're not trying to sort of ask them to do more with less. It's not like that, but it's more about creating a new role and a new opportunity for community health workers. And we recognize that's going to take time. We recognize that's, people, there are some concerns and fears because in the U.S., the scope of mental health practice has always been very guarded and protected. John mentions especially, sort of even, psychiatrists, but people are coming to realize that we can do this. We just have to do it in a way that through supervision, through peer, through all other infrastructure, we can do it and we can do it well. So I hope that we are able to demonstrate through this one, we're a very, very large health system in Texas. So I think we're a good case example and a good case study. But we also recognize that even within our own health system, it's going to take a little bit of time, take a little practice, but really do hope that we will have larger lessons to demonstrate to other health systems in the country for sure.
Can I just add? Can I add one thing to that, Gina? Yeah, I just want to make just one quick point. We don't see empower. It's not to replace the specialists. I want to make that very clear. I think it's coming across.
I have to say it all the time.
Yeah, absolutely not. No, in fact, and I think Natalie highlighted this. We work very closely with specialists. We need them. These experts are. They're experts for a reason, and we help. We rely on them to review content, to support supervision for the frontline providers we train. I mean, that's certainly been our model in India. And actually, we need the specialists on our side and to help support this. This is really addressing a major capacity gap within all health systems across the country. The other huge opportunity too is that by training, Catherine mentioned the community health workers. If they're within a health system, it's actually an ideal situation because then if there's complex cases, they could actually refer them to those limited number of psychiatrists or psychologists. So you're actually then going to be getting the more severe cases seen by the more specialized providers. So I think we should see it actually as it's also a way to make sure that complex cases are actually being treated, they're being referred, there's the proper pathway in place. And I think it's just an opportunity to also extend access to non-pharmacological care, because that's one issue in primary care in the US is it's mostly medication-based. This is true in many countries. And that's usually at odds with what patients want. They usually don't want medications. That's true in most settings as well. So this is also a way to think of how do you offer a non-medication-based treatment that has proven evidence. And then in the event that it's not effective, then there's also a way to because some people, treatments don't always work, and that's where then referral to a specialist may be needed. And having that infrastructure in place is incredibly valuable.
Mm-hmm. Thank you for that. Mindful of time, I'm going to jump back to Natalie and ask if you can tell us a little bit about the ongoing relationship between those that Empower trains and the organization and their peers. How do people stay connected to other workers and to their learning to help bolster what John was just telling us?
Yeah, sure. I think we always talk about empowered trainings, but actually what we create are empowered curriculums, and the training is just the first step. Building on Paul Farmer's legacy of the accompaniment model, what we offer is a lifelong journey and support that lifelong journey of training and education. So we all know that just one training is not enough to deliver mental health services, as mental health is a very complex field. And we want to make sure that the learners or the providers have the tools they need not to burn out, but also they are able to provide quality care to the clients. So the training is just the first step, right? And we always talk about the training because I feel it's more tangible and easy for people to understand. But we have a lot of different steps that Empower provider will go through during their learning journey. So first, the training that has a coaching support mechanism. Then we also provide tailored validated knowledge assessments, which are basically multiple choice tests to make sure that the learner understands the knowledge that has been taught during the training. But also we have created for each of the trainings competency assessments that we adapt from the WHO ones. These are standardized role plays. So someone like an actor or someone from our team can play as the client, and then the trainer has to perform as they would do in a real life session. And this allows us to actually understand if the people that are going to be delivering the training have the level of competency on each of the skills to deliver quality care. And if not, how can be supported to actually gain that knowledge and improve in those particular competencies. And then after that, we have developed a very innovative measurement-based peer supervision system, which I think is a wonderful opportunity of continue learning and improving the sets of skills also among your peers. This also allows not only to provide measures of the quality of the quality and the fidelity of the delivery of the intervention, but also allows us to understand how the system is working, how we best support those supervisions, and in the long line, in a longer term, to see how our model is sustainable, because Empower providers that gain that level of mastery can eventually become supervisors of the next generation. So, and then you can for sure take new trainings of different skills that we offer. So it's a complex model, and I would love to share more details, but it's not just the training and then we don't touch base anywhere again, anytime again with the providers, but it's more a journey that we accompany and support from Empower.
And as we've heard, there's a lot of research behind all of this and ongoing as well too. Catherine, is there anything you'd add about the research and study dimension of what you're doing there in Texas, either for supporting the workers or for the service delivery in general?
I think the thing that we're most excited about in terms of the research that we're launching is the opportunity to, one of the things that we're going to be doing is launching at a minority serving institution. So we're specifically through this training going to be recruiting students, bachelor's level social work students from who are, come from a majority minority, as we say, student body. So very almost a majority of Latino, Hispanic Latino students that will be training. They're going to be getting community health worker certification, and then they're going to get the Empower training as well. And so the real interest and goal through this work is to be able to demonstrate that we can take some folks who might typically leave an undergraduate institution with their education, but not maybe necessarily a skill set that's marketable. And we're very excited about this opportunity to be able to have them enter the workforce. They're going to be deployed within the health system for internships. We're really hoping those internships actually turn into employment and opportunity to work in medical settings, all part of this very larger kind of training program and workforce development. Again, diverse workforce development in terms of the mental health workforce, and perhaps most importantly, that through that diversity, hoping that we can demonstrate improved mental health outcomes in populations who really have been historically had poor access to care and/or haven't necessarily improved even when they do get access to care. Some of which John mentioned was around the fact that people, when asked, they actually have a preference for counseling over medication. And so if we can provide people an opportunity to perhaps get the kind of care that they are asking for and want, that we're actually going to see better patient outcomes. So that's what we've got our eye on, kind of our, we're going for we're playing the long game here, in really terms of trying to see where we can get with patient outcomes. That's the last step, and we've got all the things to do along the way, but that's where I think we really hope we can move the needle in terms of outcomes.
And that connects me back to what John was saying earlier too about the big picture next step and challenge being really scaling this up, right?
Yeah.
John, maybe to wind us up here, you can tell us a little bit about what makes you optimistic about the possibility and potential for scaling this up, and where your biggest challenge is.
That's a great question. Yeah, I think I mean I'm certainly optimistic about it. I think I think there couldn't be a better time to try to make this work. I think there's just such a a keen recognition now across the country, within health systems, just that this is really one of the single biggest health challenges across the country, is addressing behavioral health, mental health issues, substance use issues. I mean, there's no question it's the leading cause of death and young people. We're seeing this really as it is a public health crisis. But I also think that means things are aligning in a way where, with this recognition, there's also now there's an interest in moving this forward. I know when I first started working in mental health care as a PhD student, there was always questions. Well, why would you want to do that research? Why would you focus on this area? And I think that narrative has really shifted. I've noticed just in the last few years. I don't know. I think the pandemic has also accelerated kind of how people prioritize mental health. So I think that's a real, just the fact that Baylor Scott & White has been such an incredible collaborator would have been unimaginable, I think, 10 or 15 years ago. It just shows that there's now this recognition. Where's the challenge? I think some of these regulatory issues that Catherine touched on, I think these are going to be a challenge. How do you pay for this? I would say that's, one of the single biggest challenges, is that, yes, there is money flowing to address mental health issues, but there's not an agreement on how to pay for it. So yeah, there might be resources there. There's a recognition, but I think there's some pretty important details from, yes, there's, Congress will set aside money to, we're going to figure out how to pay a health worker to deliver it in a community setting when they don't necessarily have the licensure, or how do we make sure they have the licensure to do it in a certain state, in a county, wherever. This is not easy to figure out. I think it can be figured out. I think it requires getting payers at the table. I think CMS needs to be a big piece of this. I think how to involve the Centers for Medicare and Medicaid is really critical. I think how to, health systems at the table. So I think these are the kind of conversations that need to happen, because ultimately we can't expect to train frontline health workers and then have them deliver these interventions for free. It's just not going to happen. It's not realistic. This has been one of the biggest, I'd say the biggest flaw in the model in much of the global South, even though I've championed that research. A lot of these models don't involve payment to community health workers. It's not sustainable. It's not possible. We can't have health workers. It's exploitation, actually, of a frontline workforce. You're getting people to do work without paying them fairly, without fair compensation for really difficult work. So I think to me, that is the fundamental biggest challenge, is how do we pay for this, make sure it's fair and equitable compensation for the type of work that it involves. And that's really, to me, that would be one of the major challenges to ensuring success. But I am optimistic. So despite those challenges, I think there's huge optimism here, and I think across our team. I don't know, Catherine or Natalie, if you want to add.
Agree. I'm optimistic. I do think it's going to be a challenge, but I'm optimistic. We've already moved the needle in the last 2 years, I think.
That's a pretty inspiring note to end on. So thank you all very much for being here today for this really thoughtful and illuminating conversation. We hope you'll join us again for the next Public Health in Action series event on April 16th, when we're talking about healthy aging and depression in older adults, building on our ongoing Public Health in Action series coverage. So thank you again. Really appreciate your time, and we'll see you soon.
Thank you.
Thank you very much.